So today I have the honor of introducing Dr. Marc Flickinger. He's a palliative medicine doctor and over at St. Francis, mostly over there, does work for the Palliative Hospice of St. Bon Secours. He received his undergraduate from the University of Richmond in 1990. He completed his medical degree at Pennsylvania State University in 94, and he did his residency at Elgin Air Force Base. He is board certified in family medicine as well as hospice and palliative medicine. He started out part-time, but he realized that, and I'll agree, that this was his calling, and he's now full-time palliative over at St. Francis, and they love him, and I've had the privilege to work with him on some patients that I've gotten in over at Health South. So without further ado, you will enjoy his talk. Dr. Flickinger.
I'm just going to, can everybody hear me? I'm just going to talk from up here if that's okay and not use the mic. And we had a little projector issues, so I had about 8 slides I was going to show you, but apparently that's not going to work today. So I'll look over here at my some of my notes, but I'll also just talk this way. She's already introduced kind of my personal side of things. Once again, I undergrad here at the University of Richmond, grew up in Pennsylvania though, back to Pennsylvania for medical school, and then the Air Force. Thankfully for them, paid for my medical school, and then I joined the Air Force after medical school. And was in the Air Force for 7 years. Got out of the Air Force in 2001. Worked in a small town in Mount Airy, North Carolina for about 7 years as both a primary care family medicine doctor and a hospitalist. And then moved here in 2008 as a hospitalist to start out with, and then over the last 5 to 6 years I've done some hospice medicine part-time, and then joined this group with Bon Secours Palliative Medicine now for the last little over a year now. And as she stated, my home hospital is St. Francis, but we have palliative medicine providers, at least through the Bon Secours system, at each of the hospitals that they own. Memorial, St. Francis, St. Mary's, and then also Richmond Community. And I think JW here has a palliative medicine program as well on the inpatient side. We do both inpatient consults, so I'm an inpatient, I'm in the hospital and get consults from the doctors in the hospital and do consults, but we also have an outpatient program where there are 3 or 4 of our doctors that see patients in the office. They have office hours at St. Francis, Tuesdays and Thursdays, St. Mary's, Monday, Wednesday, I think, and Friday, and then they also just recently started at Memorial. And I'm going to get into some people. First part, I'll probably define a little bit is what palliative medicine is, because I think that's sometimes think palliative medicine, people think hospice. Not really the same thing. I kind of like to explain hospice is almost like a subset of palliative medicine. And so sometimes in our discussions with families, some of those discussions include hospice care, but not always. Palliative medicine, usually patients are people that come to the office to see our doctors, or we get consulted in the hospital. And in addition, people that are under palliative medicine typically are still getting all their ongoing care. So that could be, seeing your lung doctor. A lot of y'all seeing your lung specialist, going to other office visits. Often, if you're being treated for cancer, you're getting chemotherapy or radiation, and the palliative medicine team there is more than as a support team to try to kind of help manage. A lot of times, we get involved with symptom management, and so we're really pretty good at managing symptoms, particularly with people with advanced diseases, and those symptoms could be a variety of things. Could be shortness of breath, could be pain, agitation, anxiety, and then also emotional distress. Our team typically is set up similar to what a hospice team is set up, particularly in our inpatient side, where there's a physician, there's typically a social worker is with me, the chaplain often is rounding with me, and then we also have nurse practitioners as part of the team as well. And so that's kind of where the distinction kind of lays out. Typically, if you're a hospice type of patient, most of that care is being done in the home, where the nurses and the physicians, the social workers are coming to the house to take care of patients. And at that point, you've typically elected to kind of maybe change the philosophy a little bit, you're thinking a little bit where you're not wanting to go back and forth to the emergency room, not wanting to be readmitted to the hospital. You've kind of usually given up your chemotherapy or radiation or those more aggressive things, further blood work and scans, and you're really geared on treating symptoms and trying to keep you as comfortable as possible within the home setting. So that's where kind of the distinction lays out. We often help our team gets consulted in the hospital for many things. Sometimes it's symptoms, but sometimes it's just to sit down and talk with families about goals, kind of big picture. We usually get our consults are usually people with advanced diseases. We don't get consulted for typically young, healthy people, unless they need help with pain management. But usually we're consulted with people with advanced diseases that we want to talk sometimes with the patient and their families of kind of where do we go from here. And that's what I like to say as far as, do we want to continue this cycle of, maybe admissions to the hospital, or are we maybe thinking other discussions such as hospice care? We get consulted sometimes to talk about advanced directives, which we all should have. Advanced directives talks, some people use those things as a living will, medical power of attorney. There's multiple terms that we use, and we get consulted a lot to help with families working through that. You don't need a lawyer to do a medical power of attorney. You need a lawyer to do a will for financial things, but our social workers, even our chaplains, can do advanced directives within the hospital setting, and you don't need once again, you don't need a lawyer, you don't even need a notary for that. That is just you telling us who do you want to be your spokesperson if you can't speak for yourself. And a lot of times you can name a primary person or a secondary person. And then you two witnesses aside. Typically that's myself and a social worker. And so we get consulted for that. We often get consulted for things like code status, talking about would I want to be attempted, would I want resuscitation attempted on me if my heart were to stop, after I were to stop breathing. So we work on things like DNRs and DDNRs and having patients sign those. So there's a variety, and then a lot of times it's often emotional distress as well. And that's where I think it's being great that we have a team. We have our social worker and our chaplain involved, because sometimes we get consulted when people are really advanced and maybe end of life discussions, and some of those things are very challenging. And so to have the team there with you and provide resources, answer questions as far as resources out there for patients as well. The social worker, I'll tell you, the social worker I have at St. Francis, she's invaluable as far as helping me with families, kind of understanding what things are available in the community for them going forward. So that kind of goes through a lot of those things. Let me see if I think I probably went through all my slides just by talking there already. And I will say is we're really kind of a support team. When we go in to do our consults, our discussions usually are based on, all the things that the other doctors are already saying. So your heart doctor, your lung doctor, your oncology doctor, we take all of that and process that and then try to kind of help explain it to families so that it's hopefully in English and not these high doctor terms that nobody understands, and so that families understand, and then allow them to ask questions to us, and then we try to process that for them. And I think that's one of the biggest roles that we often serve in the hospital. Even if it's not managing any symptoms, at least to try to get families to understand their disease better and answer any questions that maybe the other doctors can confuse them on. And I think that's one of the number one roles that we do. We focus on relief of suffering and improving quality of life in patients, particularly once again with advanced diseases. As far as consults to our outpatient team, there's no hard and fast rule. Typically with hospice consults, if you looked at a patient and you said, hey, would I expect this, could this patient be a hospital, they may pass away in 6 months. So it's supposed to be a life expectancy less than 6 months for consults for hospice. Once again, that's not hard and fast, but that kind of is what Medicare's guidelines are. For palliative medicine, we typically say less than 2 years for outpatient. Or there's a lot of symptoms that just can't be managed, and either your pulmonary doctor or your oncology doctor or your heart doctor are asking us to help manage those. So we do that as well. So your providers can put consults into our team, and then it gets through just like any other consult. If you're going to see your neurologist or your pulmonary doctor, your primary care doctor certainly can place a consult for that as well. I think I said here, works, yeah, we work in conjunction with the other team people. I did put a little note in here, because I know specifically this is for lung and breathing issues. I did put a little note as far as helping with shortness of breath. I certainly didn't want to go into all the details of every medicine that you can use for shortness of breath, because you all probably know that better than me, given that that's why you're here. But you know, there's a wide variety of things that can cause shortness of breath that we sometimes get involved with, and that can be heart problems, lung problems, COPD, asthma, anxiety, pain is an issue sometimes that can cause shortness of breath. And so we get, you know, anemia, your blood count's really low, cancer, all those things can cause shortness of breath. We often look at all those things and make sure we have the correct diagnosis, and then we use those diagnoses to help determine what we think is going to work best to help with your shortness of breath. So if your pain's being not managed well and you're short of breath because of that, then we look at managing your pain. If you're really anemic and your blood count's not where it should be, we look to give you some blood. If there's a lot of anxiety involved, which when you're short of breath, as a lot of you know, that can be anxiety provoking. So we want to make sure we're managing the anxiety part of that as well. So there's not one medicine that does one thing. We try to look at what the diagnosis is and gear our treatment towards that. I wasn't, you know, I really wanted to not sit here and do a bunch of lecture, because I don't think that's good for this kind of setting anyway. So a lot of it really I just wanted to kind of ask if people got questions, concerns, specific questions you can ask me. I'll try to help. And then we'll go from there.
I have a question. If one is alone, what does one do? If you have nobody, no family, no one.
In the house with you, I'm assuming is what you
In
mean.
the house with you? Yeah. In the world? Whatever.
So are you asking like what help you can get there, or tell me that question?
When the last day comes,
Yeah.
what does one do? What doctor will be there? Will the doctor be there? Like you, your team, or whatever?
That's a good question. So let's talk about that a little bit. So if the last days are coming, and you're alone, obviously we can't leave somebody alone if their last days are coming. That's the first thing. Okay. So the second thing, as far as options in the community, so I'm a bond support employee, so I work with bond supports, palliative, and hospice. There's many hospices that are available in the Richmond area. There's bond supports, there's Heartland Hospice, there's Gentiva, there's Hospice Virginia. I mean, there's 8 to 10 of them. And so typically at that point, then the hospice team would be the people that would get involved to look for community resources and how we would manage symptoms at the end of life. And so just to tell you a couple options in that situation. Sometimes it may be in a facility, and that could be even in a nursing home. Sometimes it could be in a hospital. Sometimes we do now have, at least in the south side, and it's available to everybody in the Richmond area, a community hospice house that is off of Old Bonnet Road. It's 16 beds. It was built by Bond Supporters, but multiple hospices have contracts there that can go there, where particularly, like you said, end of life, where there's not anybody within the home to be able to help care for you, where it's set up like a hospital as far as staffing goes, where there's nursing there 24/7, social workers there, chaplains there, you have your own private rooms, a place to sleep for families, a kitchen, so it's set up for more families, but that may be an option as well at the end as well.